So since I have been in oncology, which is a long time, there have been some holy grail targets. The RAF-MEK pathway, which we heard about this morning, c-MYC, which we heard about, and in-MYC, the anti-angiogenesis, the VEGF receptor pathway, and the other big missing one is the PI3 kinase pathway. And we are very fortunate to have one of the true world experts on the translational development of PI3 kinase inhibitors for the treatment of malignancies, and especially breast cancer. So without further ado, I'll introduce Dr. Jose Baselga to talk to us about that.
So thank you very much, Jeff, and Bruce, thank you very much for this invitation to be here today presenting at this wonderful symposium. The field of targeting PI3 kinase, the pathway, it clearly, I think, has arisen to a moment in which it's happening and it's real. And I think we are making progress mostly in breast cancer. Now, I'm sure that there are going to be other indications, but I'd like to focus my talk today mostly in breast cancer, if I may. Now, interestingly, we have been so focused in the field of breast cancer in HER2-positive disease and so focused in triple-negative, and yes, these are formidable challenges that we have in our day-to-day care. But I'd like to put forward that perhaps where we need more advances in breast cancer today, and that's something that for all of us who've been working in breast cancer for many years, seems like the world upside down, is in ER-positive disease. That's the subgroup of tumors where, for the first time, activity was observed with therapies. We had hormonal therapies for the first time available, and we thought that this was the disease type that we could make best contributions and we could reach to more cures. Well, this is not the case. Today, we can cure more patients with HER2-positive disease than with ER-positive disease. And I think that ER-positive is becoming almost a semi-orphan disease that we need more approaches. And that's why I think it's important, the PI3 kinase pathway. This is data from the Oxford Overview showing that despite therapy with hormonal therapy, recurrence and breast cancer mortality is an issue. With available therapies, we do decrease risk by a sizable proportion. There's no question about that. But still, as you can see from these graphs, we have a long way to go. And this is what we need to really try to improve. So still a significant proportion of patients that need therapies because these patients are going to recur and they're going to die from metastatic disease. And that's where the PI3 kinase pathways comes to play. This is perhaps the pathway that is most frequently mutated in breast cancer, and it is not the same for all tumor subtypes. It is mutant in about 1/3. The gene I'm talking about now, the PI3 kinase gene, mostly the alpha mutations also, you have additional ones. It is mutant in about 1/3 of the cases, and now we have data from all the sequencing efforts that have been published in the last year in Nature by multiple groups, and the data is very consistent. So you have about 1/3 of tumors that are ER-positive that have mutations, and also quite frequently in HER2-positive disease. And I will not touch upon HER2-positive disease today, but something that has been questioned frequently is, does therapy with Herceptin, for example, or with lapatinib for that matter, how these patients respond if they have HER2 amplification and at the same time they have PI3 kinase mutation amplification. Their work by René Bernards and by our group in the lab showing that, and in small series, showing that if patients have tumors with PI3 kinase mutations, they respond less to Herceptin and they respond less to lapatinib. But until now, we did not have much data. We're going to be presenting a plenary session at San Antonio. I'll be presenting the data from the Cleopatra study. That's the large pertuzumab Herceptin trial. And we show very clearly that PI3 kinase mutations confer a worse outcome in patients with HER2-positive disease. I think this is the first time we're going to show that. It's in a huge data set. We have over 800 patients. And I think that sets the stage, at least in HER2-positive disease, to combine PI3 kinase inhibitors with HER2 therapies. I'm not going to touch upon that, but stay tuned for San Antonio because the data is quite strong. Now, focusing back to ER-positive disease, we know that there is a crosstalk between the estrogen receptor and the PI3 kinase pathway mTOR. There are several layers of evidence that that's the case. For example, mTOR1 activates ER in a ligand-independent fashion. So you have ER transcription that is driven by S6, totally independent on whether you have estradiol in the preclinical setting or not. So clearly a true ER transcriptional activator. On the other hand, if we have estradiol on board in preclinical models, there is a prevention on the apoptosis that is induced by PI3 kinase mTOR blockade. So it's incomplete, the effect. You don't maximize the effect if you have estradiol there, despite blocking the mTOR pathway. We have also gone over the frequency of hyperactivation. So I think if we look at all this data, there's a lot of sense in trying to block both the PI3 kinase mTOR pathway together with an anti-estrogen. When we started with all this, years ago, we did not have selective or pan PI3 kinase inhibitors, so the only thing we had in hand were rapamycin analogs, and that's what we studied. What I'm showing here is the phase 2 results from NCIC Canada. That's a study that was published in JCO. This is the most positive study reported with mTOR inhibitors as a single agent. And as you know, phase 2 studies are, you have to be careful when you look at the data, especially, careers are on the line. So the guys here, if they get a good data, they get a paper published, they get promotion, etc. So there is an incentive, I would say, for unbiased reporting of results. And even in that setting, the activity, it's hard for us to read this slide. Maybe I did that on purpose. But the point is that there were very few responses in ER-positive patients. There were about 3 in this trial. And again, this is the most positive. So I think it's safe to say that everolimus, which is a rapamycin analog, in this setting of metastatic disease, phase 2 single agent, has very minimal activity. Now, what happens when you combine everolimus with an anti-estrogen? And the first proof of concept was using a neoadjuvant model. That's a study that we published 3 years ago now. It's hard to believe how time flies. And this was a study in newly diagnosed patients with breast cancer, ER-positive, and they were randomized to receive letrozole plus DRAG-001, aka everolimus, or letrozole plus placebo. Therapy went on for a total of 16 weeks. And importantly, we had biopsies on day 15 on everybody. And in the case of ER therapies, the decrease in proliferation at day 15 is the best marker we have to correlate with disease-free survival down the line. So multiple neoadjuvant studies have shown that proliferation at day 15 is a good marker of an effect when you are studying an anti-estrogen therapy. And what you can see here, and I hope this is a hard slide to present. If somebody has some suggestion on how to present this better, let me know, because I've been struggling with this slide myself. But anyway, what we look here is at the decrease in proliferation. So this is here to the left are the tumors that stop proliferating, and the combination arm, 60% have less than 1% of tumor positive by this natural logarithm of Ki-67. So that's a very steep decrease in proliferation as compared to letrozole alone. So basically, 60% of tumors stop proliferating with the combination. That's quite dramatic. And that is what led later on to the design of a number of clinical trials. We designed a large phase 3 clinical trial. I'll show the data in a minute. But unbeknown to us, a group of nice French investigators did a small study on the side called TANRAD, and this study has been published in the JCO very recently. This was a study in patients with advanced ER-positive, HER2-negative breast cancer. All these patients had been treated with prior AI, either in the adjuvant or in the advanced disease setting. Small study, randomized phase 2, 111 patients, and patients were randomized to receive tamoxifen with everolimus or tamoxifen alone. Again, randomized phase 2, no placebo control, so a lot of warnings in the data interpretation, but still, I think it's something that is worth to look, and I like to present the data. And the data is here. Look at the graph on the right. I think to me that's the most important one, and that is looking at progression-free survival. And what they observed was a hazard ratio of 0.54, and they observed a substantial increase in the time to disease progression. 4.5 months with tamoxifen alone, and they went up to 8.6 months with the combination. That's important because we'll see the data in Bolero now. It is very similar, as you may be aware. And I think that when people in clinical practice are asking, do the effects of everolimus are just restricted to an AI? My answer is, based on this study, is probably no. And perhaps as a class effect, I think it is. And I would have personally, I think that with fulvestrant is going to be the same outcome that with tamoxifen and that with AI. So let's go to the Bolero study. That's the large randomized registration study. This is placebo-controlled, a 2-to-1 randomization, so everolimus plus exemestane versus exemestane plus placebo. And the primary endpoint was progression-free survival, although as a secondary endpoint is overall survival. Patients were postmenopausal, ER-positive, HER2-negative, and they had proven to be refractory to either letrozole or anastrozole. And the primary endpoint was progression-free survival, and that's what was expected, a 26% risk reduction. That's a hazard ratio of 0.74. And we had this analysis with a cutoff due to an interim analysis that we built in. And you know the data well, hazard ratio 0.43, that based on the local assessment, that's a primary endpoint, and we went from 2.8 months to 6.9 months. And then if we go by the central assessment, the data remains. Hazard ratio of 0.36, 4.1 to 10.8 months. Now, I'd like to show you some data that maybe you're not so familiar with because it's not in the paper. And this is a paper that we are gathering that I think it's interesting. So the issue that we did see a very small proportion of patients responding. I think perhaps in ER-positive disease, RECIST criteria to look for response may not be a good way to look for activity of these agents. So if instead of using classical RECIST criteria, we were to use just looking at the volume of the tumors, what happens volumetrically, then we realize two things. A, that we have a proportion of patients with exemestane that do well, that have a nice volumetric reduction, so that's point number one. But then look also at the benefit that you achieve with the addition of everolimus. Then you have a huge proportion of patients that do have a decrease in the tumor size using volume. So I think that's an important consideration to take into account. The second point that I've found, and this was something that the reviewers had concerns, and many people have concerns, is the behavior of the control arm. They said, you see, your control arm did underperform what was expected in this patient population, and therefore you have to be careful when you interpret the positive trial design. So I think this slide reflects that this is not the case. What I put here up is the number of clinical trials with exemestane in a similar patient population and see what is the reported progression-free survival. And I think it's quite similar, as you can see here, across the board. So we're talking about similar progression-free survival. Now, in terms of subgroups, do we have any subgroup that do better or worse? We had this analysis performed and with different subgroups. These were all pre-specified analyses, and we could not find something. I think that's important because people are saying, do you think this drug is going to, combination is going to be better in first line or in second line or in third line? And we don't know the answer to this, but I think that probably based on the data that we have, based on prior hormone therapy, I think probably it's going to be working at all levels, first line, second line, even in the adjuvant setting. And I think that's why SWOG is starting an adjuvant trial with this therapy. Now, the other thing that is a thing is that is this combination active in patients with visceral disease? Because in clinical practice, our tendency has been and is to incorporate chemotherapy in patients with ER-positive disease that have visceral metastases. I think this data shows that basically the benefit is the same, and there's clearly an effect in the bone as well. And this is data that we're going to be submitting for publication very, very soon, looking at the effects in the bone only. And this, of all the groups, is perhaps the group that does the best of all. There's a huge benefit in patients with bone metastases alone. Then we have data between the younger and the older group. Again, benefit in both age groups as well. And then this is in terms of the response on the clinical data. There was an update that we presented showing consistently improvement in response and clinical effect. I think the point about response is the one I already raised before, that I don't think that response is a good way to check activity with these endocrine therapies. And this is visceral metastases. And this is in patients without visceral metastases. Now, survival. And I'm sorry I missed the discussion before about survival. This drug was approved without the survival benefit. And it's interesting because it was one of the first approvals that was submitted to the FDA after they claimed that they were not going to approve any drug in breast cancer without survival. So after saying that, we went in with this as probably the first or the second study just to challenge the whole system, which we did. And that's a good discussion. I think that if you have a very strong progression-free survival data, as we did here, with hazard ratio in the range of 0.4, probably survival, there's no need for that. The data in survival is not mature. All these represent unspecified survival analysis, because every time we went to the FDA or to the EMEA, they asked us to do something that if we had done spontaneously, we would have been reprimanded, which is an unspecified look at survival at different time points. And basically, I think we're going to probably see a survival benefit down the line, but again, it's very immature. As you see, the last cutoff we have is from December last year, and I think we're going to wait until we have all the data that we need to have a final survival readout. Now, moving forward, we have other compounds that are very exciting. We have the pan-PI3K inhibitors that there are multiple of them. As part of the Stand Up to Cancer, we have been working with one compound called BKM120. And we have done a phase 1b study of the combination with BKM plus letrozole in patients with ER-positive disease, looking at different schedules. This was presented at ASCO by Ingrid Meyer from Vanderbilt, again, part of the Stand Up to Cancer group. And what we observed, I think that's the point here, is that we have a number of patients with mutations and without PI3K mutations that stay on disease, that stay on therapy for a long time. We have seen some CRs, we have seen some PRs. So this is a strong signal to move forward. And we are now undergoing, we're now conducting a registration phase 3 study called the BEL-2. That study has already enrolled, as of yesterday, 70 patients. This is in combination with fulvestrant. This study has an interesting part in the design that I'd like to share with you, because this is something that perhaps as we move forward, we need to think and ways to do things. It is critically important with this class of agents to know if responses are better in patients with PI3 kinase mutations or not. I think that's important. That's something that we need to know. How do you deal with that when the study is not being done at MGH? The study is being done around the world. When you have multiple patients that have to come in from multiple sites, and there are sites that they don't do routinely PI3 kinase evaluation. So the way we did it is as following. We say, if the patient fulfills the criteria to enter into the study, you have to send the blocks to us. And once we have the block at hand, so it's not that the block is on the mail. No, the block is with us. We've been there before too. So the block is with us. Then there is and the patient fulfills all the other criteria. So in this case, these are patients postmenopausals, AI refractory, no more than one prior chemotherapy for advanced disease, etc. They have not received hybrolymus or any other mTOR therapy. Then these patients, we have the block, they have a run-in period with the endocrine therapy. So it's not that you're waiting, because that's another thing. You cannot have a patient with metastatic disease waiting for a month or for 15 days until you have the result coming to you. It's not going to happen. You cannot, you need therapy. So you start therapy, run in. In the meantime, the screening goes on, so you have the data, and then about day 15, plus minus 3 days, based on the data that you have of mutations, then the patients are stratified and then they are randomized. So you ensure that you're going to have data on PI3 kinase mutation on both sides, on both arms, and they're going to be comparable. So we'll see how this goes, but so far we are enrolling patients well, and I think it's going to work. Total number of patients that we want is 842, and at least 300, a little bit over 300 are going to be having PI3 kinase mutations. So we're going to be able to answer this question. The other thing that we learned is that there are, when you block mTOR or you block PI3 kinase, there's a lot of compensatory talk. This is work by Neil Rosen, work by Jeff Engelman here at MGH. So multiple labs have been working on this, our lab as well. And we observed this in our initial clinical trial in 2008. When we blocked mTOR, we had an activation of AKT. And we then conducted a clinical trial with an anti-IGF-1 receptor agent, because I have not mentioned to you that the mechanism by which this occurs is via activation of a negative or release of a negative feedback loop upon the IGF-1 receptor. And in the clinical trial, we used an antibody against the IGF-1 receptor, and we observed that we were able to silence IGF-1 receptor signaling in this clinical study. And that led to a follow-up clinical study that we combined an mTOR inhibitor with an IGF-1 receptor antibody. I will not go through that. We have a lot of preclinical data that suggests that luminal B breast cancer may be dependent on IGF-1 receptor signaling. I think that's important. In the lab, if you do enhancer screens, mTOR is always a top hit in IGF-1 receptor enhancer screen antibodies. The reverse holds true, so there's a lot of rationale in the lab to study this combination. And to make a long story short, we conducted a phase 1 study on the combination of an mTOR inhibitor plus an IGF-1 receptor, showing a very profound activity. Again, this is a phase 1 study. So we had 43% of patients with breast cancer that showed some level of activity, and 54% of those patients luminal B had response. So the data was so good that many people did not believe it. We are in a field, and when we have good data, we don't believe it. We are so used to sometimes through the hardship of obtaining. So what we have done now is that we have done a randomized phase 2 study looking at this combination. Some of the patients have been from MGH, actually a lot of patients. Bev Moy has been seeing the patients as well as myself. And we have confirmed that this combination is quite active. And now we have launched a randomized phase 2 study, large study, that hopefully will address the role of this combination together with an anti-estrogen. So what we're doing is that we are combining, in this case, the mTOR inhibitor plus an AI versus the IGF-1 receptor antibody plus the mTOR inhibitor plus the AI. I think that study is going to be positive based on what we've seen in our phase 2 study here. So that's quite exciting. And then the other thing that is happening now is that we have isotype-specific inhibitors that we are also studying. The top 3 are being studied here at MGH. And I'll just present data on the first one of them, and that's BYL. I'll just pass this quickly. P110 alpha mutations are frequent in breast cancer. They are important, as we have seen. And these compounds are very selective against the isotype, the alpha isotype. This is data from BYL 719. Look at the IC50 in the wild type alpha and in the most frequent mutations. Compare this to beta, compare this to mTOR. So there's a big selectivity that's important. And in work in cell lines done by Novartis, this is Novartis data, and also in work done here by Visceral at MGH, there is clear correlation between mutational status and sensitivity to this compound in preclinical models. Here on the left, you have a panel of mutant cell lines, and in 74% of the cases, there is high level of activity in the lab. Now, not all the wild type are resistant, they're not. So about 31% of the cell lines that have mutant PI3 kinase, they're sensitive. And those include the HER2 positives, very sensitive. Those include those cells that have PI3 kinase mutations. And these include clearly other markers that we don't know yet. But I think it's important to focus on the 74 that are sensitive. So based on this, we started here a phase 1 clinical study looking at the safety of the combination, but importantly, from day 1, we only entered patients with PI3 kinase alpha mutations. And I think that's a defining moment in the development of agents against PI3 kinase inhibitors. The data was presented by Dan Jurek, a fellow at that time at the ACR meeting last year. He is going to be presenting an update in San Antonio this year. Great data. I cannot tell you. If you are interested, either talk to Dan or go to San Antonio. But bottom line is that there was a lot of activity seen in these patients. Interestingly, the activity is not all the same in the different tumor types. And this is going to be the basis for the San Antonio presentation. Again, go there. But not alpha mutations, it's not the same. So a colon cancer with an alpha mutation does not have the same outcome that a breast cancer patient with a PI3 kinase alpha mutation. So this is something that as we develop these agents, we will have to be thinking about that. Just to show you activity, so just to show the activity is real. Now, what are we doing next? So I think what we're doing next is to combine these agents with antiestrogens in breast cancer. We had a number of patients in the phase 1 setting that we knew from past history and from knowing them that they were very hormone sensitive. And if the same story that mTOR applies, and I'm sure it will, then it makes much more logical sense to combine antiestrogen. This is work done by a medical student in my lab, Jesse Tao, combining fulvestrant and BYL in a breast cancer model. And the point here, and that's a busy slide, and this is not working any longer. I'll try to. So anyway, the combination is far better, so that's important. Look at this red line. So these are animals that are being treated initially with the anti-estrogen alone, and then at one point, the BYL is being added, and you see an extra effect. So I think that's nice. So not only the combination is better, but at any given time, if you add the PI3 kinase inhibitor, you get an extra kick, and you have more tumor inhibition. And based on these data and others, the phase 1 study of BYL now is being expanded, and we have a cohort of BYL plus fulvestrant. I spoke with Dan this morning and see how many patients had he entered, and he said none because the protocol is not active yet, but it should be active pretty soon. So hopefully we will have these 20 patients coming in. When we try to do the same as we did in the past, try to see what is the crosstalk when we treat with BYL or when we treat with BKM and the ER. We have done a lot of gene expression arrays looking at BYL under different circumstances. And I'm going to show you one point that I think is interesting. Whenever we treat with BYL, we see an increase in ER levels, again, speaking to the crosstalk and to the need, perhaps, to block both. This is data in multiple cell lines based on the gene expression findings that we had in a totally unsupervised fashion. And even in animals, if we look at the tumor xenografts and we look for ER levels in tumors that are being treated with BYL, we do see, and I hope you see on the top lane, you will see that the BYL staining of ER is clearly stronger than in the control animals. And when we treat with the combination of fulvestrant, we decrease that. So we believe that if that holds true, it would be important to combine not only anti-estrogen, but perhaps estrogen receptor degrading agents. And we have a number of compounds that are going to start the clinic that are fulvestrant, or if you wish, even better fulvestrants to be checked. I'm finishing. I don't know how much time do I have left. Do I have a few more minutes? Okay, so I'd like to give you one last little story. When we began to work with BKM, we had some responses in patients with triple negative breast cancer, and we did not understand very well what was going on. But then what we realized in the lab is that PI3 kinase inhibition does induce DNA damage, both in vitro and in vivo. Here on the right, we were looking at gamma H2 AX and showed that with BKM therapy, we clearly see an increase in DNA damage. Unbeknown to us, or to me, I was talking to Liv Ellison one day about this and he told me, yeah, I've had this data for a long time. So when we were writing the paper, this data on the left, it's coming from Liv's lab, in which he had shown, again, for a long time, and he had the data there, that with sRNA, there is an increase also in gamma H2 AX, suggestive of DNA damage. So PI3 kinase inhibition does induce. So that opens then the gates for a number of combinations, right, with agents that may interfere or that might promote DNA damage. So in our system, what we did is that we began to work in combination with PARP inhibitors. This data from the paper that we just published in Cancer Discovery as part of the Stand Up to Cancer group. And what we found, and I think that's important, and you can see here on the top graphs, is that we showed that in triple-negative breast cancer, PI3 kinase inhibition induces DNA damage, and it does also induce a reduction in the levels of BRCA2 and BRCA1. So maybe there's a mechanism here. You have a decrease in the levels of BRCA1 and 2, and therefore these cells cannot repair DNA as well as they would in normal conditions. And that sets the stage for the combination of PARP inhibitors with PI3 kinase inhibitors, and a clinical trial has been started with this combination as part of Stand Up to Cancer. Now, the data that is even more dramatic than ours is the data from Wolf and Luke Canley here at the BI, They are working here in a model that is a BRCA mutant model, and these are tumors that grow very, very fast, extremely aggressive. As you can see, these animals die very rapidly due to tumor growth. And look at what they are seeing. They are seeing basically the tumors disappear in full when you combine a PI3 kinase inhibitor plus a PARP inhibitor. So very exciting. And in that clinical trial, we're also going to have that cohort in combination in patients with BRCA deficiency. So in summary, what I have portrayed to you today is that hybrolymus, an mTOR inhibitor, clearly prolongs progression-free survival in patients with ER-positive, HER2-negative breast cancer. So I think this is something that is going to become a standard of care, and our goal for the next few years is to expand this observation beyond second line. So what's happening in the first line setting, what's happening in the adjuvant setting with mTOR inhibition. I haven't touched upon the biomarkers. We have tumor blocks on everybody on this trial. So we are working with Foundation Medicine, and we're going to have a whole mutational profile of these tumors and be able to know if there are any mutations that predict resistance or sensitivity to this combination. I am very excited about the IGF-1 receptor mTOR combination. I think the data is promising. I'm looking forward to see the results of the randomized phase 2. The pan-PI3 kinase inhibitors have shown modest but real clinical activity, and there are some combinations that I've showed that are also quite promising. And then we have the data on the isotype-specific PI3 kinase alpha inhibitors. I did not cover two compounds that were on one of my slides. One was GDZ0032. Suffice it to say that there is a lot of activity with this compound as well, and it will be presented by Dr. Jurek at AACR this year. So it's not going to be just one compound. We have more than one compound from different companies showing activity. And then the last concept is that in triple-negative breast cancer, PI3 kinase inhibitors downregulate BRCA expression, and they are synergistic when combined with PARP inhibitors, and the clinical trials are ongoing with this. So I'd like to acknowledge, a lot of people from my lab. You've seen some of these names as we went ahead in the presentation. I'd like to thank in particular Mauri Scaltriti, the guy with the pink shirt. He is moving to Sloan-Kettering with me. You've seen the data of Jessie Tao, that's a medical student. She's hiding somewhere in the picture next to Mauri, and some other people also that are listed. And then, of course, the breast group at MGH, led by Bev Moy, with Steve, Isakov, Aditya, who is going to be being the local PI for the BEL-2 study, both at MGH and at Dana-Farber. And then Kerry Masman, who is a medical oncology fellow, and she's running herself a whole set of clinical trials, first in human, and then, of course, Luke Hanley and Neil Rosen and Sarat at MSKCC. Thank you very much.
Thank you, Jose, for a truly whirlwind tour through a very complicated area. So can you just very briefly, it's a huge area, but briefly touch on resistance and what types of studies globally are ongoing to address that question?
Yeah. So resistance, that's a big... So the problem with resistance is that until now, in the single agent studies, we did not have many patients to be able to study. So I'll get to you in a minute. With the Bolero 2, we have tissue blocks on the majority of patients, and we have done the Foundation Medicine panel. I've seen the data in terms of the mutations. I have not seen the clinical correlation yet, but I'm confident that we're going to be able to study at least some of the obvious things that could induce resistance, such as cyclin D amplification, I guess, or some mutations that may interfere with the mTOR pathway. So we're going to have data from that. That's one thing. The other thing that we have been doing here with Dan and with Mauri and with people at the press group is that we have had a very active program at obtaining tumor biopsies at baseline and then at progression. So we have now a number of patients that have responded, in which we have the tumor not only at the time they entered into the trial, but at the time they progress. And those samples will have to undergo deep sequencing, and then we'll get some idea on that. That would be wonderful if we could get some idea. Now, just to finish the comment, I think there are two ways you can focus your work on. One is identify what are the mechanisms of resistance. And that's the first thing we did. Let's talk about resistance. And then we are like stepping back, and perhaps the way to do it that would be easier would be, let's try to understand those that respond that well. And we were inspired by the data of David Solid in hybrolymus in bladder cancer. He had that patient that had this amazing response, and he went in and he did the sequencing, and he found the TSC1 mutation. So I think that's something that, so what we're focusing now with BYL and with the other compounds is to try to understand, if we could, those that respond dramatically well.
Great. So along the same line, could you please comment on, are those ER relapse tumors still dependent on ER or its signaling pathway for survival? Or is there any escaped growth pathway induced like acquired resistance? PI3 kinase for sure. Yeah,
so that applies as well. The issue is where to study that, because that becomes so complex. What we are doing is that we are embarking on two large neoadjuvant studies in patients with ER-positive disease, and hopefully we are going to be able to establish correlations with proliferation, because if we look at response, we can't, right? I mean, response rate is so limited that we're going to miss that. So we're going to be launching, as part of the PES International Group, two large neoadjuvant studies. One is with BKM, and that's about to start. And the other one will be with GDZ 0032 from Genentech in alpha mutant ER-positive patients.